Well, good day to everyone joining us, and welcome to today's X Talks webinar. Today's talk is entitled Osmolality as a Key to Diagnosing Diabetes Insipidus. My name is Samya Shashikumar, and I'll be your X Talks host for today. Today's webinar will run for approximately 60 minutes, and this presentation includes a Q&A session with our speaker. Now, the webinar is designed to be interactive and webinars work best when you're involved, so please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel, and that can be found on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. I would also like to welcome our attendees viewing this presentation from our LinkedIn Live event, and I encourage you to submit questions as well via the comments tab. At this time, all participants are in listen-only mode. Please note that this event will be recorded and made available for streaming to those who registered on xtalks.com. At this point, I would like to thank Nova Biomedical, who developed the content for this presentation. Advanced Instruments and Nova Biomedical are now doing business under the same brand, bringing together decades of expertise in diagnostic instrumentation, R&D, and global customer support. They are the clinical osmometer product line, including the Osmo One single sample micro osmometer, Osmo Pro Max automated osmometer, and the Osmo Pro multi-sample micro osmometer uses gold standard freezing point technology to deliver accurate and precise analysis of patient samples for maximum productivity. And now I would like to introduce our speaker for today's event. Dr. Aryan Gower received his undergraduate degree from Wheaton College in Massachusetts, followed by his medical degree and a master's in healthcare administration and management from Rosalind Franklin University in Chicago. He completed his residency at Mountain View Hospital in Las Vegas, serving as chief resident, and later pursued a nephrology fellowship at the University of Colorado. Since 2021, Dr. Gower has been a full-time nephrologist with Renal Consultants Medical Group in Los Angeles. He also serves as Associate Program Director of an internal medicine residency program, where he mentors and supports future physicians. And following Dr. Gower's presentation, we will also hear from Julie McKenzie, Vice President of Clinical Business at Nova Biomedical, who will be speaking on the devices in osmolality testing. And now, without further ado, I would like to hand the mic over to our speaker, Dr. Gower. You may begin when ready.
Good morning. Thank you all for joining depending on good morning or good afternoon, depending on what coast you're coming from. Today's topic is going to be osmolality, a key to diagnosing diabetes insipidus. Next slide, please. So the objectives today, we're going to talk about what osmolality is, what is diabetes insipidus, the clinical manifestation and the physiology behind it. We're going to talk about the 4 types of diabetes insipidus: essential, nephrogenic, gestational, and polydipsia, kind of. We're going to talk about the testing for diabetes insipidus, including the water deprivation test, how urine osmolarity is used for this diagnosis. We're going to go over some sample cases and then a wrap up at the end. Next. So what is osmolality? To begin our discussion today, we first need to define what osmolality is. Osmolality is the number of osms or osmoles in a solute per kilo of solvent reported in osmoles per kilo. Osmolarity is the number of these osmoles in a liter of solution reported by osms per liter. So osmolality and osmolarity are both measures of solute concentration, however differ just slightly in how it's calculated. But when we consider the physiology and bodily fluids that we have, the difference between osmolality and osmolarity is negligible because the body fluids that we discuss are aqueous solutions and primarily water. 1 liter of water equals 1 kilo. So clinically, these 2 terms can be used basically interchangeably. Clinically, our solvent is blood or plasma. The osmoles we're primarily looking at is sodium, glucose, and urea. Now, as we've discussed before, normal plasma osmolarity ranges from 275 to 295 milliosms per liter. Now, this is calculated looking at the effective osmolarity of each of these solutes in the plasma. Abnormal osmolarity can levels can indicate various different pathologies, including hyponatremia seen with water toxicity, abnormal cholesterol levels, or even toxic alcohol ingestion. Urine osmolarity is slightly different. Urine osmolarity can fluctuate anywhere from 50 milliosms to 1,200 milliosms per liter based on what the body needs to do to manage or preserve the amount of water in the body. It's calculated in the same manner, which includes sodium, urea, and glucose. This testing allows us to determine the expected and appropriate physiologic response to water deprivation. These abnormalities in osmolarity can then be further manipulated to determine the etiology of an inappropriate response to water management. As we discussed in prior talks as well, the utility of blood osmolarity testing is certainly important in classifying etiologies of hyponatremia or toxic alcohol ingestion. However, urine osmolarity testing can be useful for management of hyponatremia, particularly those with SIDH, but it is critical in determining and diagnosing diabetes insipidus. Next slide. Diabetes insipidus is a disease of water. Specifically, it's the lack of antidiuretic hormone or the lack of response to sufficient antidiuretic hormone. The prevalence is about 1 in 25,000 with neurogenic causes, so brain issues preventing secretion of antidiuretic hormone, being more common than nephrogenic, kidney issues preventing response to antidiuretic hormone. In Latin, diabetes translates to pass through, while insipidus translates to tasteless. So in diabetes insipidus, it is to pass through basically tasteless or very dilute urine. And that's not to be confused with diabetes mellitus, which means sweet. In diabetes mellitus, which is the more commonly known diabetes that we know, that's the dysregulation of sugar. And in the urine, you'll also often see this overflow of sugar, causing it to become sweet. Again, in diabetes insipidus, this is a disease of regulating water. So this passing of excessively dilute urine by failing to reabsorb water when appropriate essentially causes polyuria with very hypotonic urine. Polyuria being defined by greater than 3 liters of urine output in a day. Now, if this is left unchecked, hypotonic polyuria can cause a patient to become hypernatremic with symptoms that include fatigue, nausea, and confusion. Next slide. So the clinical manifestations of diabetes insipidus include polyuria and often nocturia through the night, dilute urine, and now a reflexive polydipsia where the patient consumes excess or a high amount of water to compensate for the amount of urine that is lost. And this mechanism is primarily driven by thirst receptors. The population at the highest risk of hypernatremia or high sodium levels include children, elderly, and those who are dependent on care, specifically patients with developmental or cognitive disabilities. Curiously, children may develop an aversion to certain foods, and there might be some notes of developmental delay. The common complaint that many physicians may hear from patients in the clinic setting, however, is, I'm so thirsty all the time, or I urinate so much, particularly through the night. Their labs may or may not show some mild hypernatremia. However, more often than not, you'll see that their sodium levels are on the higher end of normal. Next slide. The physiology of diabetes insipidus is important to understand in order to appropriately work these patients up. The hypothalamus is responsible for sensing the body's osmolarity through osmoreceptors. Remember, osmolarity is calculated using glucose, sodium, and primarily BUN. So when the body is outside of this normal osmolarity range, let's say if it's too high, a thirst drive is stimulated, and the patients will respond by drinking more water. In addition, vasopressin or antidiuretic hormone is produced in the supraoptic nucleus and then secreted into the systemic circulation from the posterior pituitary. Antidiuretic hormone then binds the V2 receptors by cyclic AMP in the distal convoluted tubule of the kidney. This increase in expression of aquaporin 2 channels in the collecting duct and therefore increasing water retention, therefore increasing the concentration of the urine, and therefore decreasing the osmolarity in the blood. The inability to appropriately dilute or appropriately produce antidiuretic hormone or respond to diuretic hormone is the hallmark of diabetes insipidus. Next slide. So as we've discussed in the case of central diabetes insipidus, this abnormal synthesis or secretion of antidiuretic hormone due to loss or dysfunction of the vasopressin producing cells. There are a couple of etiologies that can cause this abnormality. So we have these congenital issues such as familial hypothalamic dysfunction from a mutation in the ADH or antidiuretic hormone gene, tumors like craniopharyngiomas, pineal gland tumors, infections like meningitis, encephalitis, or tuberculosis. There's some concerns or questions that maybe an autoimmune etiology could be related to viral infections that could also stimulate this. The more common one that we probably see in the hospital is from surgery, trauma, or radiotherapy, or anytime there's really injury to that pituitary gland or the hypothalamus. Lastly, medications can cause it, primarily anesthesia. In these particular patients, there's also a reported increase in psychological symptoms such as anxiety or social isolation, general decreased quality of life. And this is suspected to be secondary to a possible oxytocin deficient state. Now remember, oxytocin is another hormone that's produced and secreted through the posterior pituitary, which is the same region that antidiuretic hormone is released. So presumably, if you have injury to the posterior pituitary or any of the pathway where antidiuretic hormone would normally be made, loss of oxytocin could be expected as well. Oxytocin is a hormone that plays a critical role in social bonding, stress regulation. Again, these particular patients, they're going to have this extreme polyuria with reflexive polydipsia when these patients are able to. Understandably, if patients are post-anesthesia or suffering from trauma or severe infections, their ability to obtain water on their own might be limited. These are the patients who are acutely ill in the hospital, who we often see this rapid rise in their serum sodium levels as they do not have access to free water on their own. Next slide. The other flavor of diabetes insipidus is nephrogenic diabetes insipidus. These particular patients have poor, incomplete response to antidiuretic hormone. This can happen from two primary reasons, either congenital or acquired. The congenital ones are secondary to a vasopressin 2 receptor mutation, which 90% of the time is X-linked, or aquaporin 2 gene mutations. In either of these pathologies, it's the inability of the receptor or gene to function despite appropriate antidiuretic hormone. In the acquired cases, you can have intrinsic kidney disease from polycystic kidney disease, sickle cell, or renal amyloidosis. Other causes include metabolic derangements from hypercalcemia or hypokalemia, which are presumed to decrease the collecting tubule's responsiveness to antidiuretic hormone. Lastly, medications can cause it. The main one that we see a lot is lithium. Lithium-induced diabetes insipidus, specifically nephrogenic flavor, occurs when lithium enters the kidney's collecting duct cells through the epithelial sodium channel, the ENaC channel. Inside the cell, lithium can inhibit the effects of antidiuretic hormone, which leads to decreased water reabsorption. It also causes a cellular change such as reduction in aquaporin 2 channels and buildup of prostaglandin E2, both which disrupt the kidney's ability to concentrate urine. Now, clinically, the particular etiology of DI can be managed with this particular etiology of DI can be managed through amiloride, which blocks lithium's entry specifically into that principal cell from the ENaC channel. And by blocking its uptake, then treat the DI by restoring the urine concentration and the ability of aqua tube expression. Next slide. Gestational diabetes is another etiology. In this particular pathology, you have an increase in metabolism of antidiuretic hormone due to placental vasopressinase. This can usually start within week 8 of pregnancy and will peak around the 3rd trimester until birth. In some rare cases, it can continue on after birth for the next few following weeks. Next slide. Now, primary polydipsia is a disorder characterized by the ingestion of large quantities of water that results in hypotonic polyuria. It is important to note that this is in the setting of appropriate and completely normal functioning antidiuretic hormone and response. So the challenge is this mimics the values that we would typically see in diabetes insipidus. However, in this case, the polydipsia is what actually drives the polyuria instead of the other way around. These patients drink a large amount of water, which causes very dilute urine. These etiologies are often psychological and can be attributed to certain medications as well. The key difference to this pathology is twofold. So unlike your true diabetes insipidus patients, these patients are more often than not mildly hyponatremic, although often will have normal sodium levels. In addition, as they have normal physiology, once they're fluid restricted, these patients will actually have sodium levels that will remain normal. In addition, with restriction, the polyuria actually resolves once the water intake is limited. Keep this in mind because this is a distinguishing factor from true diabetes insipidus, where the fluid restriction will often cause sodium levels to become very elevated with continued polyuria despite the fluid restriction. Next slide. Testing. For testing, it's important to rule out other causes of polyuria. So remember from our calculations of osmolarity, high glucose levels with glucosuria can cause polyuria. Diuretics like Lasix or Bumex can also cause polyuria. Medication that can cause an osmotic diuresis, such as urea or mannitol, or even excess amounts of normal saline can also cause polyuria. And lastly, as every college kid learns at some point, alcohol can also contribute to significant polyuria as well. Once these other causes of polyuria are ruled out, as we mentioned on the prior slides, the testing for diabetes insipidus is often initiated with a dehydration or water deprivation test. In this setting, patients will often limit their fluid intake for about 12 hours with frequent urine studies looking at both volume and osmolarity to determine the appropriate response of the kidney. Furthermore, vasopressin challenge can be done once the diagnosis of diabetes insipidus is made to confirm the actual etiology of if it's neurogenic or nephrogenic. Next slide. So our water deprivation test, like we mentioned, evaluates the kidney's ability to concentrate urine in response to either endogenous ADH stimulation or exogenous desmopressin. This test is a little bit different on the inpatient setting and the outpatient setting. We're going to talk about both now. Next slide. So hypernatremia in the hospital. So in the hospital setting, it's not often required to do a true deprivation test because most patients we get consulted on for diabetes insipidus rule out are often already hypernatremic. In fact, one of the pathologies to rule out on anyone who comes in hypernatremic should be to rule out diabetes insipidus. As long as the patient's already hypernatremic, however, they're already going to be hyperosmolar, so there's no real need to conduct the deprivation portion of the test. We start the evaluation by checking the urine osmolarity. If the urine osmolarity is high in the setting of hypernatremia, then this is appropriate. Remember, when the body's hypernatremic, it is attempting to hold on to all the water, and in doing so will concentrate the urine, causing the urine osmolarity to be appropriately high. In these cases, the etiology of the hypernatremia is more often than not due to lack of water intake. We typically see this in patients who may have underlying dementia coming in from nursing facilities, again, without access to free water on their own. If the urine osmolarity is low, however, this would be concerning for diabetes insipidus. In these patients, you would expect, in the setting of hypernatremia, that you'd actually hold on to water like we mentioned. However, with a low urine osmolarity, it would imply that there is very dilute urine despite the body's appropriate desire to hold on to water. A dilute urine in this case would be considered inappropriate. Now, as we mentioned before, we need to rule out other causes for osmotic diuresis in patients, particularly in the intensive care unit. Next slide. In the clinic, it's a little different. So as patients with diabetes insipidus can have high amounts of urine output, unlike the hospital setting, in the clinic, testing should be done with a little more caution. Unlike the hospital, hemodynamics are a little more challenging to monitor, and the patient who crashes in the clinic will be much harder to resuscitate and care for. In the clinic, it's important to check their baseline weight, their vitals, their plasma osmolarity if possible, their serum sodium if possible, and urine osmolarity and urine output. The testing must be stopped if a weight loss of greater than 3% is noted, a sodium level greater than 145 milliequivalents per liter is obtained, or if the plasma osmolarity becomes greater than 295 millimoles per liter. Lastly, it should be noted without mentioning that if the patient becomes orthostatic or develops severe symptoms of hemodynamic instability, this testing should be stopped. Urine osmolarity is then rechecked 4 hours and 8 hours until the urine osmolarity plateaus within 2 samples, demonstrating less than a 10% change. In a normal patient, you would expect the urine osmolarity to increase appropriately with continued fluid restriction. However, in a patient with diabetes insipidus, the urine osmoles will remain less than 300 millimoles per liter, which will often support the diagnosis of diabetes insipidus. Now, like we mentioned, although diabetes insipidus can be confirmed by this deprivation test, it does not distinguish between central or nephrogenic. Next slide. So this is a brief summary of kind of all the numbers that we discussed with the deprivation test. So if the urine osmolarity can become greater than 600 milliosms per liter, that would demonstrate a normal concentration ability of the kidney. In this case, primary polydipsia should be considered as diagnosis for patients with polyuria and polydipsia. If a urine osmolarity is less than 300 millimoles per liter, it demonstrates an impaired antidiuretic hormone effect or response, typically consistent with diabetes insipidus. Again, in the hospital setting, a solute diuresis should be ruled out as well. And finally, there's this middle ground where the urine osmolarity is between 300 and 600 milliosms per liter. In these particular patients, a partial DI could be considered as well. Next slide. The desmopressin stimulation test does help us identify the etiology of the diabetes insipidus. The test involves giving synthetic desmopressin to a patient and assessing through their urine osmolarity their body's natural response to desmopressin. In patients with central DI, as they are restricted, they're just missing the ADH component. So by introducing antidiuretic hormone to the body, the kidney should naturally respond to holding onto water and seeing that urine osmolarity concentrate. In the setting of nephrogenic DI, however, they do not respond to antidiuretic hormone. And so you can give them more and the urine osmolarity will not significantly change as the body cannot further concentrate their urine. This testing can help distinguish between nephrogenic and central DI. Next slide. So you can see, again, as mentioned, in central DI, you'll see this robust increase in urine osmolarity after DDAVP. If there's minimal to no change in the urine osmolarity after DDAVP is administered, then be consistent with a nephrogenic DI. And lastly, if there's this intermediate increase, then a partial nephrogenic DI could be considered. Next slide. Treatment options. So the reason why testing is so important is because we need to test in order to figure out the etiology and distinguishing between nephrogenic and central DI. The reason is their treatment options are quite different. In central DI, you give the body what it's missing. In this case, you can administer desmopressin oral, intranasal, or even through IV to help titrate the appropriate output you can expect and monitor the urine osmolarity for a patient and try to achieve a goal of appropriate urine output in a day. It's important to also educate these patients on what to expect. So in this case, you're giving them desmopressin, and there's a possibility where they can actually become hyponatremic, particularly if they're not eating adequate solids or if they're drinking water in excess. So it's going to be important to monitor their urine output as well as monitor their urine osmolarity and their serum sodium levels. The treatment for nephrogenic DI is to address the cause if possible. This would include stopping certain medications or addressing underlying metabolic electrolyte derangements or avoiding certain offending drugs. In the case of lithium-induced nephrogenic DI, for example, diuretics can be used to help cause a mild volume depleted state, which would then help regulate antidiuretic hormone. In addition, like we discussed, we can utilize amiloride to block the introduction of amiloride through ENaC channel in the collecting ducts, limiting the effect of lithium. Lastly, certain diets, including a low-salt diet, can help the body's management of water in the kidneys as well. Next slide. Now, we do have to, there's a couple pitfalls and reminders that we've kind of alluded to previously. Low solute diuresis improves improves with solutes, however, diabetes insipidus does not. So in chronic kidney disease in particular, due to the decreased kidney function, the range in which they can dilute and the range in which they can concentrate their urine drops pretty significantly. So in a normal healthy kidney, you can expect it to be anywhere from 50 milliosms to 1,200 milliosms per liter. But in chronic kidney disease, that may be limited to maybe 400 to 500 milliosms per liter. We didn't talk a lot about pregnancy, but remember, that ADH system is fully intact in the pregnant patients, and they just have an enzyme, the vasopressinase, that breaks down antidiuretic hormone. So if you can introduce high enough doses of DDAVP, you should be able to overcome this loss, and that can be shown to be a proven effective treatment for gestational diabetes. In patients who are being treated with DDAVP for nephrogenic DI, you should, again, monitor for hyponatremia, as these patients can be used to drinking high amount of waters before being treated on therapy. Any water that they consume while on DDAVP will potentially be reabsorbed in the body, making them at risk for hyponatremia. The goal of the treatment is to make these patients as normal as possible. This requires the patient to have anywhere from 1.5 to 3 liters of urine output each day. Next slide. So we're going to talk about some clinical cases and see if we all understood the utility of urine osmolarity testing to help guide our diagnosis. Next slide. So in our first case, this is a post-op central DI patient, 48-year-old female, post-transsphenoidal surgery, noted to have 7 liters of urine output each day. Sodium is 149 milliequivalents per liter. The plasma osmolarity is 303 milliosms per liter with a urine osmo of 130 milliosms per liter. Our interpretation of this is, despite being hypernatremic, we would expect the body to hold on to water as much as possible. However, the patient is having high urine output that is relatively dilute. This is inappropriate. The patient then undergoes a deprivation test where the urine osmolarity does not change significantly. This would effectively rule out primary polydipsia as our etiology. After administration of DDAVP, we see a significant increase in the urine osmolarity and the body's ability to concentrate urine. So this testing would be consistent with essential diabetes insipidus. The treatment modality in this patient would be to be dosed DDAVP, monitor urine studies, and serum studies. Next slide. Our next case is a lithium-induced nephrogenic DI. So here we have a 35-year-old male on lithium, 6 liters of urine output. Sodium is 146 milliequivalents per liter with a plasma osmolarity of 298 and urine osms of 180. After DDAVP, there is only a marginal increase in the patient's urine osmolarity, which would be consistent with a nephrogenic DI. Now, clinically, he could stop the lithium. However, a lot of times for these patients, lithium is one of the few medications that truly work for bipolar disorder, for example. And as a nephrologist, it becomes very tough to tell that patient that you have to get off therapy. So with consultation with their psychiatrist, we would try to decrease the dose or see if there's any other medications the patient can be on. If they can't and need to stay on lithium, we can consider medications like thiazides or amiloride to adjust and augment how they respond to the lithium. Next slide. Our third case is a 28-year-old athlete with marginally low serum sodiums at 134 milliequivalents per liter and a plasma osmolarity of 273 milliosms per liter and a urine osmolarity of 280 milliosms per liter. After the deprivation test, we can see that the urine osmolarity increases to 620, which confirms our diagnosis of primary polydipsia. Now, some questions of why this isn't a partial DI, for example, well, it's because the urine osmolarity did significantly improve without intervention, and this would be pretty classic for a primary polydipsia case. In terms of management for this patient, we would really work on fluid behavior counseling and ultimately implementing some kind of fluid restriction. Presumably, this patient would be consuming a high amount of water or fluids each day, and helping them back away to a normal amount of fluid intake would then be the appropriate treatment option. Next slide. In gestational diabetes, we have a 32-year-old female in her 3rd trimester with a sodium of 147 milliequivalents per liter and a urine osm of 160 with no pituitary history. After giving DDAVP, we see the urine osmoles go up to 450 with symptoms that get relieved. So the mechanism in this case would be consistent with placental vasopressinase that degrades antidiuretic hormone. In this case, we'd administer DDAVP, and that would be most beneficial for this patient. Next slide. So in summary, urine osmolarity is whatever it needs to be for your urine to adjust to your body's appropriate need and balance of your serum or plasma osmolarity. Your urine, essentially, your kidneys will augment however they need to augment to maintain normal. Unfortunately, in patients with diabetes insipidus, which presents as a primary water problem, they have an issue with that ADH access through either creation, secretion, or response to antidiuretic hormone. We can utilize urine osmolarity only to diagnose diabetes insipidus, but through testing and augmentation of the studies, we can help distinguish between what type of diabetes insipidus they specifically have. And such testing can be done both in the hospital and the office setting. However, again, remember in the clinical setting, in the clinic in particular, it is a little more high risk in terms of patients collapsing. Keep in mind, a lot of these patients are peeing out 7, 8, 9 liters of urine each day. And with that much urine output, there is a concern for hemodynamic collapse. And so it should be done with caution. Next slide.
Hey, thank you so much, Dr. Gower, for sharing that important use case for osmolality testing. I'm Julie McKenzie, and I'm going to talk a little bit about the technology behind it. So osmolality is measured using an instrument called an osmometer, and in hospitals, it's absolutely critical that we use what's called a freezing point osmometer. And why? Well, that's because freezing point is the only method that isn't affected by alcohol interference. The other method you may be familiar with, called vapor pressure osmolality testing, can give inaccurate results when alcohol is present. And that really matters because toxic alcohol ingestion is one of the key reasons we run these tests, osmolality. Accuracy is everything. So if we go to the next slide, many of you may be familiar with advanced instruments osmometers, now under the Nova Biomedical brand. And these instruments have been trusted in the field for over 70 years. On this slide, you can see a history of the advanced instruments osmometer models. The latest models at the bottom, the Osmo Pro Max, the Osmo Pro, and the Osmo One are shown in gray, and the discontinued models are shown in blue. And I wouldn't be surprised if any of you in the lab see or have any of these in the lab, especially the older ones. They're really workhorses in clinical laboratories. If we go to the next slide, there's no question the discontinued models were groundbreaking for their time, but at Nova, formerly Advanced Instruments, we move fast when it comes to innovation. And our newest models that I mentioned, the Osmo Pro Max, the Osmo Pro, and the Osmo One, are built on feedback from clinical laboratories. We believe very much that ideas for next generation products come from the lab, from the people that are using the instruments, from the people that are managing the laboratories. And we spend a lot of time in these labs collecting that feedback to inform our next generation products. All of our newer models focus on automation, better data connectivity, and reducing errors. For us, it's much more than just an osmolality result. We see accuracy as a given. If we don't have accurate results, then that is a different question. But building on the accuracy, it's around the workflow that goes around that. And at the end of the day, making the lives of the techs in the lab running these instruments easier, because at the end of the day, there's a patient on the other end, like Dr. Gower talked about, that are dealing with serious conditions, and osmolality is critical in the investigation. If we go to the next slide, wanted to show you the main differences in the models that we offer. The Osmo One is the more manual of the models. You aspirate the sample and load it into the instrument one at a time, extremely robust. The Osmo Pro is semi-automated. You load the samples into test cups, one or a few at a time and run the tests. And the Osmo Pro Max, all the way on the right, is our fully automated osmometer that allows you to load the primary tube, so no pipetting is required, and you can run one or multiple samples, really the highest level of automation. But I want to clarify, when we say the highest level of automation, often labs think, maybe it's not for me, I don't need a ton of automation. But the way we've designed this instrument, the Osmo Pro Max, is that it's not just for high volume labs. Our goal, our mission is to make automation available for every lab to make their workflow processes easier. I haven't been to many labs where people aren't busy, people aren't running around, and we want to make it our job to make your lives easier. So that's a bit about the technology used to measure osmolality and really the technology that's so critical to deliver results for these important use cases that Dr. Gower mentioned. And with that, I'm going to turn it back over to Samia. Thank you so much.
Well, thank you very much for that insightful presentation. Now I would like to invite our audience members to continue sending their questions or comments for the Q&A portion of the webinar. If you are attending via GoToWebinar, please feel free to use the questions window. For those of you watching on LinkedIn Live events, feel free to post your questions in the comment section. Now, I have already received some questions, so we'll start with those. Now, the very first question we have here, this audience member wants to know, what are the advantages of using osmometers in-house over other methods for osmolality testing?
So I can answer that one. I think the in-house testing gives you timely diagnosis in speed. So having someone in the clinic and trying to evaluate if they have diabetes insipidus, for example, you must have in-house testing. This is not a send out and see what the lab results come back at and then make an adjustment based on that. You really need kind of live testing in order to do that. Again, these patients can pee 7, 8, 9 liters of urine a day. And if you allow them to stay fluid restricted for that extended period of time without a definitive diagnosis, you do risk kind of a hemodynamic collapse. And so the ability to be able to test in the office setting would be critical for the workup of diabetes insipidus.
Perfect. Thank you so much for that answer. Now, our next question, I think this is for Julie, and this audience member wants to know, what is the Advanced QC Peer Group Program?
Sure. So the Advanced Instruments QC Peer Group Program is a program that's available for all of our osmometers in compliance with regulatory guidelines, things like Joint Commission or the College of American Pathologists, who require laboratories to demonstrate peer-to-peer comparisons. Are they running in line with other labs for osmolality testing? Are they running high? Are they running low? So we have a program, the Advanced QC Peer Group Program, that you can navigate to through our website, where you can enter your control results on a daily basis, on a monthly basis, and get those monthly reports to see how you're trending. This is completely free of charge. It's provided with all of our osmometers. And on the Osmo Pro Max, remember that's one of the osmometer models that we have, that actually happens automatically. If you decide to use that feature, transfer of that control data to the peer group program is done automatically.
Perfect. Thank you so much for that, Julie. Now we have another audience question for you. And this audience member wants to know, what sample volume is needed for your osmometers?
Sure. So it does vary a bit. Anywhere from 20 microliters to 190 microliters would be the smallest sample volume size. So both the Osmo 1 and the Osmo Pro, 20 microliters per sample, whether it's serum, plasma, urine. For the Osmo Pro Max, because we're providing primary tube functionality, the instrument does need to see a bit more volume. And so that's where a minimum volume of 190 microliters is necessary.
Perfect. Thank you so much for that. Now we have another audience member here asking, is there a difference between the reference interval for serum and plasma? Dr.
Do you want
Gower?
to take that one, Dr. Gower?
Yeah, I'm sorry. I'm not a little confused by the question. So serum, in this case, the serum and the plasma osmolarity would be the same. So generally it's 275 to 295 milliosms per liter. So that's the typical reference range.
Okay, perfect. Thank you so
I don't know
much.
if that answers the question. So I guess to further, if you're higher than that, you're hypertonic, and if you're lower than that, you're hypotonic or hypoosmolar. And that can kind of give some insight to etiology if you're looking at plasma, if someone has a true hyponatremia or not.
Thank you so much for that. And we have another person asking, what volume of water intake is defined as polydipsia?
So I'll take, Julia, I'll take this one. The general kind of guideline is greater than 3 liters would be considered polydipsia. Now that is in context. So if you're a sports athlete and you're consuming a high amount of fluids because you're sweating a lot, I wouldn't say that you will have polydipsia because of your insensible losses and the losses that you have through sports and in general exercise. But for the average person, if you're drinking more than 100 ounces of water, that would then technically be considered polydipsia.
Well, okay, thank you so much for those answers and for all of the answers. We have, however, reached the end of the Q&A portion of this webinar. And now, if you couldn't attend to your questions, the team at Nova Biomedical may follow up with you. Or if you have further questions, please direct them to the email address on your screen. Thank you everyone for participating in today's webinar. You will be receiving a follow-up email with XTalks with access to the recorded archive for this event. And a survey window will be popping up on your screen, so your participation is greatly appreciated as it will help us to improve our webinars. Additionally, I have also shared a link to view the recording of today's event in the chat box, which you can also share with your colleagues so they may register for the recording here as well. Now, for those of you watching via LinkedIn Live events, we encourage you to visit xtalks.com to register for this event and gain access to features such as viewing the recording and more. Now, please join us in thanking our speakers for their time here today. We hope you found this webinar informative. Have a great day, everyone, and thank you for coming.
Thank you so much.
Thank you.